Okay, enough of that. I am now excited to introduce our first keynote for the day. Dr. Jessica Elizabeth Isom is an early career community psychiatrist, public speaker, medical educator, and consultant for diversity, equity, inclusion, and anti-racism projects. Driven by a passion for collaborative leadership, she takes pride in providing the conceptual frameworks and psychological safety necessary to expand the growing edges of her clients and peers. Dr. Isom draws on her psychiatric training and humble background to connect across differences in power, education, and perspective to foster a collaborative approach to achieving racial justice and equity in medicine and beyond. As a resident in the Yale Department of Psychiatry, she was selected as Chief Resident of Medical Education and as the Chief Resident of Diversity and Inclusion. Her strong training background and leadership experiences inform her current role in Boston, Massachusetts at Codman Square Health Center. She formerly served as a leader within the American Psychiatric Association Assembly, where her contributions centered on illuminating the need for health equity in organized psychiatry. She was also elected to the counselor position for the Massachusetts Psychiatric Society, where she served for 1 year. Within the Yale Department of Psychiatry residency program, she is a faculty track leader for the Social Justice and Health Equity curriculum. Currently, she's devoting considerable time to growing her consulting company, Vision for Equity, LLC, which she has expanded into a nationally sought-out team of anti-racism coaches and organizational trainers. So please welcome Dr. Isom to the stage.
All right, good morning. So I am going to keep myself honest to 45 minutes. I've gotten better at this over the years, but I always give folks the preamble that you'll get the slides, so just relax. There's lots of references on the slides that you can review later. So I focus more on just being present. If you want to take notes, you can take notes, but you will get the slides. So let me use this clicker. One thing I'll point out from all that stuff in the bio is I currently do workforce development with psychiatry residents in the Yale Department of Psychiatry in the Social Justice and Health Equity curriculum. And a lot of what I like to focus my limited resources on is workforce development. I think it's useful. I am a physician who went through medical school, went through a school of public health, went through training, and I am intimately familiar with the inadequacies of our training experiences. So a large part of what I'd like to focus on is just filling in those gaps that are present to actually achieve the goal of the title of the presentation. So I'm going to start with a discussion of the urgency, and then go over a bit about racial histories and racial socialization and how it's relevant to this topic. I'll then talk about some of the manifestations of racism and pain management, and I'll end with what a racial equity focus can look like in pain management. As far as the urgency, it's always interesting. I am a person who trained in academic programs. I'm very much familiar with the academic culture, and there's a depersonalized approach to a lot of the work that we do, but none of what I do is not personal. So two things. One, this is my family, and I don't know if you can tell which one is me. I was a smiley child, and my 5-year-old is the same. So my mom is here, and she's someone who has experienced a number of chronic conditions, but one of the things that she experienced was a fall, and she actually broke her leg and ended up in rehab. So it was an interesting experience joining her along her rehab experience. She could not walk. Then she was on crutches, and she actually recovered. My father and my mother were both in the military. They're both veterans. My father retired after 22 years of service, and he now accesses care in the VA system, similar to my mother, and he's dealing with chronic low back pain. So he is a patient who receives services from many of you here present in this space. I also put pictures here of children because we often think that we don't touch children and how racism manifests in what we do, but we do. The data is pretty similar for both children and adults. So not only was I vulnerable to these experiences as a child, my own child is, your children might be, depending on how you're socially positioned. But just to humanize myself for a moment, I experienced a pain injury here at this conference. So my friend from medical school came here last night to see me, to have dinner. I was letting her in the gate. I was so excited to see her that I didn't realize the gate would close down, and it closed down on my face. I'm okay. My glasses are broken, there's glue. But the point is that for me, it's like, how much of an injury did I experience? What kind of care might I need? And I needed none, just some rest. And then what will it be like once I get there? And those like additional considerations of what my care experiences will be like are part of the problem that's highlighted in the presentation today. So no worries, I'll be fine. I can replace my glasses. So with that said, it's very important for me to acknowledge the elephants in the room. I'm not really quite sure how I ended up walking into mostly white spaces talking about race, racism, and whiteness. But for that reason, that there is a texturedness to this space, I think it's helpful to acknowledge that it's here and also invite us all to participate in that. So one, you are hearing from a person who's a Black woman. I'm also of high weight. There are a number of factors that will influence how you experience me in the space. I'm also talking about a really taboo topic that we're not supposed to talk about. There's lots of rules to race talk, which I've talked about in other spaces, but just know that I'm breaking all of them. I'm also taking away I'm also taking away from other things, right? I'm drawing your time, I'm drawing your other resources to this topic. I recognize that that's a tension that's there. There also might be new information. We're naturally resistant as human beings to being presented with that, so we have to deal with that together. I'm also making people uncomfortable, which is a part of just having conversations that need to be had, and I'm elevating what can be referenced as a subjugated counter-narrative, subjugated as in suppressed, counter as in counter to the dominant representation of what we do and how folks experience the care that we offer. So what I'm asking you to do is basically adopt a learning mindset. There's lots of things that we do in learning spaces like fight, flight, freeze, and fawn. Try not to do those things. If you notice them happening, kind of shift yourself. Just make sure that you're listening, that you're doing something with the information and your reflection of it. If you have questions, ask, or if you have comments, same thing. All right, so there are other places where this is explored in more detail. For example, there is a CME on the American Psychiatric Association website that I did that talks about racial socialization in great detail and its connection to us as healthcare professionals and our perpetuation of racial inequities. It's free, so that would be a place to get more information, but I'll just talk about it a bit here. So in summary, what could be reviewed in like years of study will be on the next 3 slides. And how I like to talk about racism is just one way. There are other ways as well. And I like to talk about the roots and how that produces what we see and focus on as far as disparities. And one of those roots is cultural racism, which can be described as the way that we make meaning of cultural groups and racial groups in ways that are either denigrating or uplifting. So we have cultural narratives, the stories that we tell. We have cultural images, the representation of other human beings and their cultures. We have cultural norms, such as the norm to not even have this conversation at all. We have cultural values, such as valuing individualism over collectivism or community-oriented approaches to life. We also have, as a part of this culture, stereotypes, we have bias, we have prejudice, and we have discrimination. That's a part of the root that produces the fruit. Something else to note is that the part of the roots that we don't often talk about is our developmental history. We have an ahistorical approach to our training. For me, my history of psychiatry was focused on mostly white men and some white women, but no like social or cultural context for how we developed our theories and things of that nature. So this is pulled from a book on the history of psychiatry and psychology, just showing that we all developed as professions, as fields, alongside things such as race-based slavery and colonialism. We influenced them, they influenced us. It should be a part of our formulation of what we do and why we do it. There's also structural racism, which folks have talked about a lot more openly in the past few years. And this just manifests itself in structures, things that shape the way that we are able to access opportunities for health and well-being. So school, workplace, housing, healthcare, law, justice, everything. And then in the middle of this graphic, it just shows those different kinds of manifestations, such as access to good education, segregation, redlining, all the historical stuff that's important to note. What that produces, essentially, are racialized access as well as experiences and outcomes. And at the bottom of this graphic, you'll see that there. So underemployment, unemployment, discriminatory experiences, low socioeconomic status, low access to wealth, all that good stuff. And that's the story in like 5 minutes, but we're gonna just move on, okay? Because we spent like decades talking about this story. I encourage people to access more information about it, but it prevents us from getting to the end of the presentation, which is the part about what to do. So I like this cat story because, again, it kind of condenses this big, like, scary topic into something very simple that you could explain to a 5-year-old and you might try. This is going to show us the cascade from information to discrimination, and peppered throughout, there'll just be some elaborations relevant to the talk. So you have a cat person here. They are looking at the news, or you have a person here, my apologies, I don't know what they are. They're looking at the news and they see crime rates by race, and they're saying to themselves, oh my, cat people have the highest rate of crime. So they're accessing some information. They then draw a conclusion that's generalized, such as all cat people must be very dangerous. That is a representation of a stereotype. They then have an attitude, thought, and also behavior that's not related to the specific cat person, but more so to the stereotype. And that's represented here by seeing a cat person in a grocery store and saying, why are you staring at me? I'm only here to buy my milk. So they don't know the person, but they have this often negative attitude, negative emotion, negative behavior towards that individual. Then you have bias. They own the store in this one, and they have a preference for who should be in that store based on everything that was described previously. So they're saying, oh my God, look who is here in my store, and they don't look happy. They might actually look scared. And just to stay there, because we often talk about bias a lot, which is like one piece of the story, one piece of the problem, and one piece of our solutions. You've probably seen at this point a lot of information out there about bias. So there's explicit forms, there are implicit forms. I'll show you some videos that show that there is explicit bias. It exists, despite our real commitment to kind of 5-year-olding stories about the reality of our country. So it is real, and I'll show some videos. So explicit attitudes and biases, you know that they're there. You can reflect on them, you can monitor them. There's this concept of like front stage, backstage. Lots of research out there that examines whiteness. So front stage, backstage would be on the front stage, folks are making comments, recognizing that on that stage they might be around racial others. And the backstage, it's mostly homogenous, mostly all white people, for example, and the conversations are different, the jokes are different, the tone is different. So that's an example of consciously monitoring our bias in ways that are dictated by where we are. And then implicit, unconscious, automatic, all those sorts of things. The paper referenced here is lovely for anyone who wants to get really nerdy about how this works at the level of brain structures and how they're connected to each other, but I will move on for now. Something else to note is this is the study that talks about the divergence of bias. So they looked at 6-year-old, 10-year-olds, and white adults. And when they asked these 6-year-olds, 10-year-olds, and white adults, do they have an explicit preference for their own racial group? Of course, the 6-year-olds proudly said yes. The 10-year-olds did a little bit more moderating, and then the adults were less likely, but as you can see, it was not zero. They did this, again, through the IAT, trying to see what the implicit association would be, and they just found that it's similar across all groups, which just represents that we learn how to express our preferences, how to express our biases in ways that are socially acceptable. That does not mean that there's not something beneath the surface that drives what could be discriminatory behaviors. So just another interesting study. So then we get to the end of this cascade from information to stereotype to prejudice to bias and now at discrimination. And thinking about discrimination is very difficult. I am a healthcare professional. I'm not like a magical person. I discriminate too. It happens. I think the approach to it that's more healthy, as opposed to lots of shame and guilt, is to accept it and then figure out what to do. And we have to figure out what to do. So this is a representation that I like, because it adds complexity to what we do all the time as we interact with help seekers. We are health providers in this image. Of course, I encourage you to read the paper, but I'm just gonna walk through the image just to show you all these places where that cascade with the cat people is relevant to what we do as healthcare professionals. So I've put blue dots where the letters are, so we're gonna do A, B, C, and D first, and then it's elaborated on the left side of the slide. So essentially, we see a help seeker, we gather information from them about who they are and what they are, as far as like stigmatizing characteristics sometimes. You should know that in the first milliseconds of meeting each other, we've been conditioned to appreciate age, sex, and race. That's just what we do. So we do that at A, and then we have our own beliefs about this help seeker that are informed by how we've been socialized, and that can influence how we interpret the symptoms. And then, of course, from there, we make decisions, and we also decide, to a certain extent consciously, but also unconsciously, how we're going to interact with that person. Our interpersonal behavior, of course, affects the help seeker, the person that we're offering help to, and that's illustrated here in E, F, G, and H. So our interpersonal behavior might increase or decrease our level of satisfaction with us. It might produce within the help seeker, for example, stereotype threat, where they might become preoccupied with what you might think about them. It might influence how they ask or don't ask questions, what they ask about, et cetera. And ultimately, all of this is happening, hopefully in visits that are longer than 15 minutes, but it's happening, it's there, it's present, and we have to be attentive to it because it doesn't always translate to, and often doesn't translate to, offering high quality care. So I think if you haven't had any exposure to this type of cascade, please read the paper. Zescott is great at talking about bias as it relates to healthcare professionals. And if you haven't been exposed to it, it says something about the quality of how we have this conversation and, of course, the solutions that we come up with. So who here has heard of the unequal treatment report from the Institute of Medicine? Not many people. So it came out in 2002/3. It was commissioned by Congress, largely led by the Congressional Black Caucus. And it set out to find out, does racism impact the care that we provide? That was the question in 2003, which is an interesting question to ask in 2003, but they asked it. They produced a, I think, 700 to 800 page report detailing that the answer is yes. That there is an impact that affects quality of care, access to care, and successful treatment outcomes. The cool thing about this, there are executive summaries, there are briefer elaborations, is that it really picks apart what we're talking about when we have a conversation about disparities. So yes, definitionally, disparity means difference. People often will argue, well, a difference is a difference, doesn't mean it's racism. This might be a helpful way of, as a conversational tool, kind of unpacking that in those conversations where there's a barrier presented in that way. So there are differences, and they pull out that a part of that difference is at the top right, people's needs and their preferences. And then they highlight that the disparity is an avoidable part of their interaction with the healthcare system and also with us as healthcare professionals. And that's the disparity represented by that bar. So it's interesting to think about the rules of academia. We don't often value folks talking about their experiences. We don't really put enough value on subjectivity. And it's interesting to be at a pain management conference where everything that you all do involves subjectivity. So maybe this will be a different kind of space, but a lot of us in healthcare are resistant to things that don't have numbers or don't seem logical or things of that nature. But if we were more open to it, we'd look at all these studies out there, and this is just one, that show that there's just something that's not going as well as we would like it to go as healthcare professionals. So this paper set out to just find out what are the patient-reported experiences of discrimination. And just to highlight, discrimination, like many other words, it's multifactorial. So yes, there are interpersonal components, but institutions themselves can discriminate too, such as whether or not they offer access to interpreters. So in this study, the 5 most commonly reported types of discrimination were race and ethnicity, education or income level, weight, sex, and age. And as you can hopefully appreciate, we're all kinds of things. We're not just one thing. So for myself, I might have some experiences related to my weight, maybe my age, and also my race and ethnicity. I'll also say, contrary to popular belief, educational level does not always protect you from experiences of racism. So for example, in birthing, it's terrible. So there's not always that protection, but I personally do have some because I present as someone that's had some education. So most folks who did report discrimination also said they had experienced it more than once, so it's a repeated thing. And what I want to now talk about is the contradiction between everything that I just presented and then how we are socialized, most of us, if not all of us, and some of us have varying levels of other aspects of socialization that counter it, but we're socialized into just misunderstanding all of what I just said. So I came across a really cool resource. I actually watched every single clip. Obviously, I'm neurotic. There's 44 of these. This is the Whiteness Project. It's free online. Half the clips are from millennials, I think in Texas, and the other half are from working class or blue collar, I think, or white collar professionals in Buffalo, New York. So this is a Buffalo, New York white collar professional. There's going to be a millennial and then another white collar professional, and we'll just listen to what they have to say. I'll say this, I've heard these clips multiple times and it still raises my blood pressure. It'll probably raise yours too. So anyone who doesn't want to hear what they have to say because they've had enough, you don't have to listen. And you can decide to leave, I won't take it personally. Each clip is about a minute to a minute and a half.
Do I think it's beneficial for me to be white? If I gotten any privileges like that, I would say no. Just plain and simple, no. I think that, with civil rights and everything, I think a lot of times that other minorities sometimes get more benefits than I would as being a white person. For some reason, some black people kind of hold on to the, back in the day, the slave thing, or they feel they're not being treated right. Should slavery be something that, because it happened, we owe black people something more? Absolutely not. Like I said, it had nothing to do with me. It had nothing to do with black people living today. Maybe their great-great-great-grandmother went through it, someone they never met, but it's in the past. There's been injustices done forever in human existence. And it's just something that shouldn't happen. But it doesn't mean I owe anyone anything because of it. I think it's hard to talk about race as a white person because I feel like maybe sometimes black people are just looking for a reason to tell you why you're wrong or tell you why you owe them something. If I was in a room full of white people, I would not feel uncomfortable talking about race. But if there were other minorities in that room, I might think a little bit different, and I might be a little bit more careful opening my mouth to not offend anyone or to potentially get in an argument or a heated debate.
All right, so this is Jason. Jason's cringeworthy, and at the same time, there's aspects of Jason in people in this room. So one thing I'll say openly is that I appreciate these clips because they do represent something that for a lot of us will feel aversive to listen to. And at the same time, it's important to not defensively, even at like a lower level than conscious, not see yourself in Jason. So there's pieces of Jason in all of us in this room, whether it be Jasons that were present before we developed a critical racial consciousness that allows us to see the world a bit differently, or just whatever exposures that we've had that have produced at least a pause in response to some of what Jason has to say. Jason could be a physical therapist, occupational therapist, physician. I've met him as part of my colleague basis. So a lot of the other work that I do outside of this kind of workshop approach is helping people deal with the Jason within and the Jasons amongst their teams, because racial equity work requires Jason to be on board. So a part of this development of a skill set in racial equity work is figuring out how to understand others' racial ideologies and then be responsive to them in ways that move them along, and also, as you'll see, put some accountability structures in place so that Jason's feelings don't matter, right? At the end of the day, he still has to offer care that's, equitable. So we'll listen to Leilani.
I think I don't think about race because I don't talk about it. And the modern society is so obsessed with preventing a problem that all they do is talk about the problem, and that just fuels the problem. So, if we want to get rid of racism, stop talking about racism. And just stop. And it's really not that hard. The reason I don't think about it is because I wasn't raised talking about it, because it didn't matter to us, because we were all different colors, but we were all family. So we saw each other as a family member, an aunt, an uncle, a niece, a cousin. We didn't see each other as Asian or white or German or whatever. We didn't see that. We saw this is someone I love, not someone to be judged. And so I think that's the way that we could stop talking about it, is if we stop seeing each other as objects and start seeing each other as people, start loving each other more and not judging so harshly.
Sounds beautiful. I mean, I wish. They were socialized by someone, so they put a pretty clear thread between how they think, feel, and behave, and who they've been exposed to, and that includes other grown-ups. So this last clip is pretty. I'm trying to think of a word to say professionally, but it's kind of disgusting, actually, what this person has to say, but I think it actually represents prejudice very well. There is an element of disgust involved in our interactions with folks who are stigmatized, inclusive of races and ethnicities, but also other factors as well. You might consider, if Deanna was talking about a person who's unhoused or who has, HIV, we know what it feels like to be disgusted or revolted by something. The point of this is to just make the, connection between this exists out there, and of course, Deanna might be a professional who offers pain management. She might not talk about this openly at work, but this, of course, influences how she interacts with the folks that are seeking her help.
We're going to talk about Black men in general. Very beautiful people. So when you smile and you say hello, that's not an invitation to follow me, come to my door. I have a convertible to pull up next to me. I don't, I'm just being friendly. I would smile to a woman or a kid or a dog in the car, any person. They take that as a opening to approach. And as I said, as a voluptuous woman, I seem to, they seem to gravitate that way to me, and it's just not comfortable. So, do I call it prejudice that I don't like that? I guess it is in a way. I don't like that. I'm afraid, so.
All right, I'm afraid of Deanna. And I think the lack of insight, obviously, and recognition
about Black
that the
men in
fear can
general.
go both ways, particularly for help seekers seeking healthcare services, is something that needs to be elevated more. All right, so we've gone through the Whiteness Project, and I just want to make the connection between those folks and what the data shows as far as us as healthcare professionals. I think we have been socialized into thinking that we're special, and we're not. So like all of the data out there is directly applicable to us too, but of course we need data to support that. So they've done some studies specifically on healthcare professionals to help us develop insight, basically. So this is one that was done on reflections on racism in healthcare, not only from professionals, but also from help seekers, which I'm not gonna go over. I don't think so. So these are some of the findings. These were qualitative studies that they reviewed to pull out these key findings. So one, we often construct ourselves as neutral and impartial, as if we're robots and not human beings. We do have a lot of difficulty accepting that prejudice is a part of our healthcare interactions. We're socialized into that because we're not prepared as we're developing as a workforce. Majority, which here is referencing white healthcare workers, express white racial socialization in its dominant form. That includes dismissing racism as existing or being a thing of the past. There's often a focus on individual level racism and not anything beyond that. We don't know what racism is. Most people don't. Actually, we're, again, socialized into a misunderstanding. And then we often think of race as biological, which is a huge topic as far as it relates to pain management, excuse me. Anti-racism training is not new. It's been around for a very long time, decades. When they had looked at these studies that talked about the training, faculty members don't typically discuss it. Faculty members are uncomfortable discussing it. Whiteness itself, which I'm not going to have time to elaborate on, makes it difficult. And whiteness includes things like how white racial socialization creates the things that make it difficult for us to talk about these things, and also create consequences for having the conversation at all. People experience the discussion as polarizing as opposed to our existence in the structure as polarizing. And then also, there's some good stuff here that there is a development of empathy after anti-racism training intervention. All right, so this is the part I spent so much time looking up papers, and I was like, oh my God, this is so overwhelming. I do this in lots of different spaces, but pain management has so much. So you can read the slides. I'm just gonna reference these, and then I'll make the point as to why on the last slide. But there's lots of stuff there, and I included references throughout. Just to make the point, pain is subjective. There was one study I saw that's trying to create some device by measuring something in the blood to detect pain. There's research trying to make it more objective, but we're just not there yet. Pain is experienced differently by different people, which I'm sure you know. There's lots of different care involved in pain management, lots of different types of treatment. As far as how pain is experienced across races and ethnicities, everyone experiences it relative to the comparison group, which is often, if not always, white people. These are the numbers for non-Hispanic Blacks, Hispanics, and non-Hispanic Asians. So the numbers just represent this is something that exists. The largest demographic is for non-Hispanic Blacks outside of the comparison group. If there is one slide, it's not exhaustive, but this would just capture the point that when I say racism, what I mean is not just calling someone a racial slur. There's lots of things here, and this is not exhaustive, but internalized racism can affect the provider-patient relationship. You can internalize feelings of racial superiority, and you can internalize feelings of racial inferiority. So your perception of your own competence could be shaped by internalized racism in ways that are exaggerated or underestimated, which is super complicated and also important for us to think about in our interactions. Treatment adherence could be a part of that too. As far as organizational racism, do we adopt the culturally and linguistically appropriate services standards from the federal government or not? Are we equity-minded in our organizations? Do we think about our workforce as far as hiring and promotions? What are our grievance procedures? I work with 85% Black patients across the diaspora, all kinds of different lives as a community psychiatrist. Much of what I am talking about with them, as far as their experiences with other people, is about discrimination. So you should file the report or not. What are you going to say or not? How can you elevate your concern beyond the organization or not? So lots of support around grievance procedures, which reveals there's a lack of transparency around how you do address experiences of discrimination, which of course supports us in maintaining the status quo. Interpersonal racism would be things like measures of perceived discrimination, how we assess pain and treat it. And then structural racism would be things outside of sort of the clinic or hospital or treatment center, such as insurance, financial resources, how flexible folks can be with making it to appointments, and all those sorts of things. So we're going to do a whirlwind 5 minutes through this data and just make the point, I'll say simply, that racism affects assessment, treatment, and quality of care. It also affects the workforce. Again, if you want to nerd out, there are lots of different types of studies that expose people, that are retrospective, looking at records, or expose people to things like faces and measure the kind of assessment and treatment that they come up with, and how it might be disparate or not. So this is one example of that. Looking at faces, we are complicated creatures. So our ability to connect with another's experience is technically basic, like we are supposed to be able to empathically connect and receive another's experience inclusive of pain. However, our socialization distorts our ability to do that, and also working with out-group members is more challenging as well. So this just found that looking at faces, there was an under-recognition of pain on Black faces relative to white faces. It's also important to note that cultural communication of pain differs, so not everyone's vocal or feels comfortable doing so. So being able to read someone's nonverbal communications of pain is very important. Some other stuff, a study at the VA found that Black patients were less likely to be screened. Other studies have found that advanced diagnostic imaging is racially disparate across groups. As far as treatment of pain, the opioid conversation is exhaustive, lots of different resources to dive deeply into that. But in summary, less access to opioids and also lower doses, and then more punitive measures if something happens that's a human thing, such as a urine drug test not being what it's supposed to be. So more punitive measures in response to those occurrences for Black patients versus white. Pharmacies, just like locations of things that are like healthy food, they are less likely to be in areas that have a high racial, ethnically minoritized population. They also are less likely to have adequate supply for managing pain in the form of opioid prescriptions. And also some more data that connects experiencing injustice and discrimination to increased pain burden. Quality of care is different. There's a number of studies here that show even when you control for things like access to insurance or going to the same place, that there's just lower quality care offered to Black patients and others. A lot of these studies do focus on the Black-white binary for reasons that are consistent with the history of this country. But also, I encourage folks who do want to nerd out to look at other demographic experiences as well. This is for quality of care. Cancer patients that are in a nursing home were less likely to receive pain treatment. And multidisciplinary care, there's a lack of offering the full complement of care to Black patients, and then their outcomes are not the same. So less likely to report that their pain severity had reduced relative to non-white Hispanic patients. Referrals are different. They have gone through much more Black patients before they are referred. Their likelihood of actually making it to the referred place is reduced as well. And then this study at the bottom here, it just shows that when you do like an artificial testing condition, there is an influence of race and ethnicity on how people assess pain and also how they offer treatment. And this one's interesting too because I think we all appreciate the connection between, bodily physical health and mental health. And here, the holistic offering, for example, of antidepressant treatment was also different. Referrals to physical therapy are less likely. Black patients also attend PT less. This is across different settings. And also when controlling for other factors, that finding remains the same. And then I think this is the last one, almost. There's also a disparity in how quickly folks get to physical therapy. And this is just from a paper that illustrates some considerations. I think it's helpful because when I say racial equity and pain management, it's things that we all can appreciate. It's not as complicated as it might sound for some. It really is just paying attention to how these other factors like timing of the services offered, transportation, insurance, all those sorts of things will shape the experience that folks have, for example, in physical therapy or not. The workforce is overwhelmingly white. This is just one representation of that in physical therapy. I'll say simply, humans are diverse, you need diverse workforce. There's nothing else to say about that. So there's some work to do there. In a nerdy sense, the work is also around being exposed. So for example, if I was on your team, I would influence you in some way, right? And one of the ways that I would influence you, like based on studies, is that your empathy for people like me would increase, like your understanding, like your cultural fluency, all those sorts of things. So it's not just like throwing minoritized people on flyers, it's actually developing intimate relationships with them in ways that can help support you offering higher quality care. All right, thank God it's over. The statistics are just like, oh my God. But the point is that people don't change because they've been seeing studies. But the point of all of that is that nobody wants to undertreat a kid's pain. Nobody wants to undertreat my pain at a conscious level. So we have to figure it out. And I'll close with basically talking about what that can look like. So one thing that's really helpful is thinking about quality improvement efforts through an equity lens. This website is solvingdisparities.org, and it basically has everything you could possibly need. It even has 33 examples of QI projects that had an equity focus, and what they offer is this roadmap to basically reduce the disparities that I've just described. QI work is just as racially evasive as our culture is. What that means is that there's not an acknowledgement of all of these things in our approach to QI work, which often leads us to improperly define the problem, which often includes pathologizing people. Like, they're just not doing the things that they need to do, and that's why these numbers are the way that they are, as opposed to a more holistic consideration of what's contributing. So if you want to know, for example, how to do it, it even talks about number 2, creating a culture of equity, which is easier said than done. But one main part of that is actually data. So my question for y'all would be, who disaggregates their data by race, ethnicity, and language at your individual provider level or at the organizational level? Is anybody doing that? Yeah, so we don't even have data, right? That's a part of the culture, that's a norm, that we don't even have to look, but we do. So for example, in my clinic, I am working with the Suboxone team on anti-racism and opiate use disorder. They disaggregated their data for the first time, working with a majority Black population, and they found things like nobody that is receiving MAT is a non-English speaker, for example, and we have tons of language diversity in our catchment area. They found that co-prescribing of Suboxone and benzos was only for white patients, 6. They were all white. There was an overrepresentation of white service users in an area that was overwhelmingly Black. So there was an underrepresentation of Black patients. So it's like, wow, we have data now, but that step is huge for people because they think if they don't look, it doesn't exist. So I would encourage you to just look at your data at the individual provider level and at the organizational level, because that's a part of creating that culture. And then the rest of the information flows from there. So on one slide, like, what is a representation of what you can do? There's lots here. My suggestion is figuring out what you would like to start with as a focus area, or what few things you'd like to start with, because you can't do everything. So there are some individual focused suggestions here, and there are also some that are institutional or organizational. Some of this stuff is already happening in some places and not in others. Some is just not happening at all. So as I go through, not to approach the information thinking about what appeals to you or feels feasible for you and your organization would be important, because otherwise you'll end up in this place of analysis paralysis, which is inaction in the face of need. So I'm not trying to do that. However, I'm supposed to do what I'm supposed to do for the presentation. So this is an equity mindedness prescription. I adapted this equity mindedness concept from an educational space to make it relevant to healthcare. It was for educators in classrooms to be equity minded, and for us, it's not that different, but it includes essentially having some level of racial consciousness, committing yourself to just understanding how you and histories impact those around you, feeling like it's relevant to you enough to be held accountable to doing something about it, which is a huge lift, and the work that I do, and then finally understanding structures in addition to personal. This one slide, I will probably, and this is kind of, it's just true. This one slide probably won't even happen before I no longer am present on this earth. Like, we are incrementally getting there. I have seen people who are in their 70s now just seeing the fruits of their labor as it relates to racial equity work, and I'm very happy for them. But I think it's also important to be honest with myself and transparent with you all that it takes lots of time. So there are folks who are gonna take lots of time just with bullet number 1. And that's why the final thing, which is accountability, is so important, because some people just are not gonna come along, and some organizations are not gonna adopt what needs to be adopted. So for anyone who wants to know what's the data for debiasing strategies, it is here. This is a paper that summarizes what's effective, relatively more effective than other things. You can take a look at it. All the stuff folks talk about in implicit bias talks is summarized here. And I'll say briefly, it can be effective. However, it's one piece of the solution pie. And then as far as organizational, I talked about the point of diversity. Yes, it's to make it equitable as far as access to being in certain places and having a certain impact, but it's also about helping us socialize each other to offer better quality care. So these are some representation of folks doing this at different levels. I was a National Health Service Corps scholar. I was gonna work at my clinic anyway, but I appreciate the loan repayment funding to do so. And that helps basically redistribute the workforce to places of greater need. But even within organizations that have diversity, they need to do some other stuff to create a climate, a culture that's conducive for folks working together successfully, and of course, offering the care that's necessary. So these are the organizations in my world that help to hold other organizations accountable, and also the AAMC and others are, moving along and becoming better at incorporating this as well. Just to make this point in a different way, What we typically do with disparities efforts is represented here in this blue squares. We just do something that's not equity focused and we don't know what's going to happen, and we often don't look at the data. If we were to look at the data, we would note that maybe it's neutral, the impact. Everyone gets better or the number gets lower, but the disparity is still there. We might have a narrowing of that disparity gap, or we might have a widening of it. So it's so important to disaggregate the data. There are health equity learning collaboratives out there. I'm participating in one, and they are very much focused on not just the intervention, but how it changes the gap. That's the focus of their effort. JCO is coming for you. As of January 2023, they are an example of external accountability. They want to see that we are working on disparities and can demonstrate that in ways that we can actually write down. The class standards, very straightforward. They help us do what we were supposed to do culturally and linguistically. As far as the workforce, this is a paper that I wrote with some colleagues that talks about how to do training in a way that's increases the chances that it's effective. Training is one part of it, but we can at least do that part well since we're investing so many resources in it at this time. So if anyone wants to know or is in charge of allocating resources or leading trainings, this is a helpful reference to look into so you can do it well. And then also the AAMC has some competencies that might be incorporated as we are looking at each other and trying to figure out if we're progressing or not. Also, some considerations would be educational programs that directly confront the myth of biological race, standardizing our care, and then also trying to incorporate objective measures wherever we can to help reduce how much the human contributes to lower quality care. This is a longer list, which I'm not going to read, but these are examples of developing that culture of accountability. There's no way I, as an individual, even with the best of intentions, can be a psychiatrist that just does everything perfectly. It's just not possible. I require external accountability to get better at that and to sustain the improvements that I do make over time. So these are examples of ways to support individuals' good intentions and actually resulting in some demonstrable impact. And with that said, I want to close with this quote from James Belasco and Ralph Steyer. Change is hard because people overestimate the value of what they have and underestimate the value of what they may gain by giving that up. And I would love to have done decades of service that close the gap in some way. It's more meaningful to me than just being a regular psychiatrist. So I hope that you all feel the same as well. And with that, I'll close.
With the red dot. It was perfect. Okay. All right, well, thank you so much. How about questions from online in the room?
Or comments or feelings are welcome as well.
Yeah.
Thanks so much. I'm not sure how this is going to come out. It's formed in my head. I just don't know if I can get it out correctly. But you mentioned, and correct me if I'm wrong, that you work with, one hat that you have is that you work with people like Jason in like the workforce, or try to sort of show them that there's a whole different world out there, I guess.
Yeah.
And I'm thinking it was kind of part of what we were discussing last night a bit too, but coming from a patient perspective that has pain, a lot of, the session doesn't go well when you sort of speak to them or sort of invalidate wherever it is going on. And I'm guessing you can't tell someone like not to be racist, the same thing. So how, Jason's exist in my family. Like I know Jason, so rather than, I think, shutting them out of my world, right, isn't really changing anything. It might help me, but it's not helping them. So could you speak to sort of what that looks like in the clinic or when you work with somebody of how you sort of plant those seeds that change needs to happen?
Yeah, so I'll say, to clarify, I don't have Jason patients.
Oh, okay.
Yeah, so, well, I mean, maybe I do, but they don't tell me. They don't say things like that to me.
I'm sure you do.
I was more so saying in a workforce development space, I work with white people and who are clinicians of various forms. And there's a diversity of racial ideologies within those groups. And the main part of it for me is getting them engaged in not even necessarily agreeing on the problem and how it's defined, but at least adopting the solutions, right? Like you need to have an interpreter and the services that you offer because that's just the thing that you're supposed to do. Doesn't necessarily require that foundational understanding. I'll say there's an entire report. It's called Anti-Racism, What Works? And it summarizes the studies that demonstrate what's successful versus what's not. And it's complicated. Context matters, relationship matters. For example, I can say a whole lot more as an external consultant than I can say as someone in the organization, which is why I do external consulting, so I can speak truth, right? But I still have to develop relationships with folks. So there's a skillfulness that comes from my psychiatrist background that can do that, if that makes sense. So there's like creating a space, acknowledging the full person. This is an aspect of their experience, blah, blah, blah. So that anti-racism, what works would be a professional approach to this, the answer to your question. Personally, though, to be quite transparent, would never expose myself to a Jason. It would never happen. It would result in racial stress and also racial trauma. So it's not the labor that I would adopt. So there's in ways I could read about what to do, but I have not done it as far as lived experience. So I think in this room, there could be a conversation around how people have done it who know Jasons intimately in a different sort of way, right? But you do have the power of your relationship, which I don't have, right? You also are from the same demographic. There are things that come from being an in-group member, such as trusting what you have to say, that you're saying the truthful thing. Things that are helpful, one thing I think it's like a 20-page document, it might be 8, derailing for dummies, or like racism for dummies. It's like a thing that shows how folks derail race talk, all the strategies that are used, such as humor, attacking the messenger, all these sorts of things. So when I'm talking to white people, I'll say, and really anyone, learn how people show up in race talk, number one, and then know how to counter what they offer from the script, because it's a script. So I've spent years learning the script. So if you arm yourself with that, then you can enter into the conversation with some knowledge that helps you strategically move in the relationship, but it might take a long time, right? But at least when Jason says, slavery was like 500 years ago, what's the big deal? You can look at the document, read what it says, and then just keep pushing along rather than wasting time on figuring out what to say. If that makes sense, it helps you become more efficient and effective. So if someone reminds me, I can send it. But derailing race talk, if you Google it and you find resources, it'll help you navigate those conversations with Jason.
That's great, thank you.
Mm-hmm.
My name is Dr. Erica Merriweather. First of all, thank you for existing in the space as you are.
Mm-hmm.
And even though we are Black women, we are not the same, and we don't have the same experiences with this. So in your workforce development work, I'm part of that 2.2% of PTs. So does it address the fatigue that comes with being part of a person, being a person in these spaces with, an intersection of multiple identities? Does it speak to the majority of how to deal with it, or does it address the people in the room who live it?
It's difficult. I'll say there's narcissism to whiteness. There's narcissism to any dominant identity. So me as like a cis hetero, feminine appearing woman, there's narcissism to my experience of that identity, which means much of what I care about and I'm focused on is about me. Me. So I'll say developmentally, most folks early on are only receptive to that me part. So for example, what do I know? What do I don't? What do I not know? How do I feel? Like I feel guilty, I feel ashamed. There's a empathy gap. And that empathy gap, when crossed, gets to, okay, well, how does all this make sense to others? And how does all this impact others? And folks struggle. I'll say, for me, in the containers that I'm handed, those containers often feed the narcissism, right? We're gonna come here and we're gonna talk about this thing and we're gonna focus this on the majority audience of white folks. There are some containers, and by containers I mean like a grand rounds talk or some kind of workshop. There are some containers that have shifted to focus on what is the experience on patients, for example, or what is the experience on folks as members of the workforce. But I will say, from really intimate relationships with clients that have evolved over time, a lot of their empathy comes from their experience of people that they love. This is very psychological. So in loving me as a consultant, sometimes there's an evolution to cross that empathy gap and actually deeply feel how painful it is to be a person like me, if that makes sense. So later on in the journey, there might be like apologies. For example, I'm sorry we traumatized you, or I apologize for the things that you've experienced. So in a developmental sense, it can take time for people to get there. I think in a professional sense, as far as the approach to the work, we do feed that narcissism. So for me, for my own, company and my own work, I am thinking through how to not do that, how to not feed that. But it is difficult based on the container that's offered and then how much risk you're willing to take. Because they might say, we don't care about your pain. We just want to hear about, how it affects us. So it's a very, very, very good question. And maybe it's something that should be written about, right? And I'm happy to write about it with you. And there's plenty of people that can join us and write, because it's true. I don't think that everything I just said, I don't know if that's written anywhere at this time. I'm not sure. So just let me know. Or just let me know if you have a student who has less work on their plate that you would recommend. Okay. Yeah.
Wonderful. All right. Do you have any questions online or no? I didn't see the flag.
We did have a question. I think it's very similar to what was being posed earlier. I asked them if there's a further question. I will still just read it. Like, how do you address embedded inequality in close relationships, work and social? Follow-up to the question is, how does one initiate raising a voice smartly?
I missed it, I think because of the mask.
Yeah.
Sorry. How does one initiate raising a voice smartly? And the first part of the question is, how do you address embedded inequality in close relations, work or social?
In close traditions?
Yes.
In the workforce?
Work or social?
Work or social? I don't know if I can answer that question in in 18 seconds. What I would ask. Okay. I'll say this simply. I'll say, how do you address what's embedded? The first step is to illuminating that it exists. So revealing that it's there, and that requires careful consideration of the things that we often just accept as not a big deal. So one concrete example would be, and I always go back to this interpreter thing because it's something I work on. What does it mean that we rely on family members, for example, to interpret for patients? And then, yeah, it's what I was taught to do, but what might the impact of that be, for example, on healthcare-related communication? I also will say being critical is not sexy. So people regard people who are critical, who do try to think about things more deeply and intentionally, as aversive, which is just true. So a part of it too, if you are the person engaging in that work, is just to accept that there's people that might not fancy you. And at the same time, that's just a part of what has to be done. So that's my simple answer, is illumination. And then also, if you're gonna do the illumination, preparing yourself for the response that you'll get, because folks enjoy homeostasis as humans, and you're rocking the boat inherently by illuminating anything at all. So I hope that's helpful. If it's not helpful, then just email the question.
I thought it was great. There were lots of great quotes in there, actually.
Yeah.
Okay, do you mind answering one more? We have one more in the room.
Yeah, sure.
Okay.
Thank you very much. I want to say I'm Baram Jam, and I feel I'm a better human being after listening to your talk, so thank you. Yeah. I was born in Iran. I've lived in Toronto for the last 45 years of my life. And I wanted to just emphasize that if you agree with me, I don't think this racial issue is an American problem. It's not a black and white issue, that it's a human issue. that it does exist pretty much in every country, in every race. I'm from Toronto, which is one of the most multicultural cities in the world, I could say, and I see it and experience it. I'll give examples being, if you go to the Chinese community in Toronto, they will not accept, for example, the doctors there, I know I'm saying it's the same politically, they would not accept somebody who's non-Chinese into their practice or even treat them. If you go to the Indian part of the Toronto, they would not see any white patients. Like, they're discriminating against white people. So it's not just a white thing. It exists in my grandfather in Iran, because we were a religious minority compared to Iran. If you're not of Islamic faith, he died because he wasn't treated by the doctor, because he was considered not worth treating. So saying it exists every part of the world, so it's not an American issue. Canada exists, across the world it exists. It's not just whites that are discriminated, or blacks get discriminated against other cultures. Every culture does it. And I'm happy that you're talking about it, though. Would you agree with me in that?
So this is where the importance of language is key, and also understandings of words. And I was with my friend last night, so I couldn't go to the meetup. So the it that you're referencing, the it could be stigma, the it could be prejudice, the it could be stereotyping, the it could be in-group favoritism, the it could be lots of things, and yes, that's represented across the world and across human experiences. However, if the it is racism, and the way that I understand it and race scholars understand it, there's a distinction there. And I would encourage anyone who says yes to what you just said to find the distinction, what's different. So I'll say very simply, stigma would be another way of having this conversation. Different groups experience different types of stigma and level of stigma. If you look at the Black experience across a number of different identifiers, whether it be sexual orientation, gender, class, Black stratifies everything, right? That supports its representation as a stigmatizing characteristic that's rigid enough to be across the United States. But then if you look at skin tone globally, that as a stigmatizing characteristic is global, right? So in any country that you go across the world, that skin tone variation is gonna be worse, the most severely experienced by darker peoples, right? And even if you looked at heart disease, diabetes, any kind of experience, you'll find that stratification related to skin tone, but specifically in the United States related to being Black, right? So I would say that distinction is what makes it different than, for example, some of the things that you mentioned, such as a preference for a healthcare provider. Now, what makes that stigma relevant? Power, right? So the power to label a group with a stigmatizing characteristic and then reinforce that with structures, right, is different. So if I go into a healthcare setting here or in any other country, I'm kind of brown, so not the same as my sister, but that experience is dictated not just by the stigma, but also access to power. I can't change how I'm gonna be treated here in this body, and I can't change how I'll be treated in Iran with this skin tone. That's the power associated with stigma. So that distinction could be helpful for folks that are acknowledging other its, like prejudice, stereotyping, bias, and things of that nature. But the distinction is the part that will help this conversation. So that's my nugget response to what you've offered. So I don't entirely agree, right? There are elements of it I agree with, but I think we'd have to really hammer down like what we're talking about to come to an understanding.
Thank you very much.
You're very welcome. Thank you.